Thanks, Dr. Kumar, and very good afternoon, everyone. I want to share two challenging cases for Kumar's course. Now, this was a small child with bilateral lens coloboma, and you can see that it was intersecting his pupil, needed to be treated. So we decided that we'll start with making, we have to fixate, and we made this groove incision just inside the limbus, and made a Hoffman's pocket. I see more and more people shifting to the Hoffman's pocket. I've been doing these for a few years now, and they really work well because they preserve the conjunctiva, and the suture knots get buried nicely. So once your Hoffman pocket is ready and you're sure that it has reached the area where you want it to reach, you can then make a rhexis. You have to, of course, plan the rhexis in such a way that once this lens is recentered, this rhexis should ideally become fairly central. So while there is no sure shot way of doing that, but you can plan it in such a way that it will become central later. And of course, you have to plan that you should be able to put in the lens through this rhexis as well. The risk is also that if you make this rhexis too close to the area of the coloboma, you will not have enough hold on it if you want to put in a capsular tension segment. So of course, these cataracts are all really soft, and you can aspirate them very easily, but you have to be careful that there is no collapse of the bag, which can cause problems for you, and you can fill it up with viscoelastic. And now what we are trying to do is to check whether this bag will actually be, we'll be able to pull it all the way to the side for fixation. So once we are satisfied that it will work out, we can put in a CTR to distend the bag, and after that, once the bag is nicely distended, you can then implant your lens. Now the plan here is to put in a CTS or a capsular tension segment, the Ahmed segment. It's also available in India as the Gupta segment, and very similar to the Ahmed segment. Aiki Ahmed is the guy who invented this. He has been with me on my courses for almost 10 years now. He's a brilliant surgeon, and this is a brilliant device. For those of you who still haven't used a capsular tension segment, it is a very, very nice device which can be positioned where you want for the subluxation to be tackled. It's more easy to handle this than the Sionese ring in most cases. Now here we are passing a needle through the Hoffman's pocket all the way through, and we are doing the railroad technique here to ensure that this comes out correctly. And then we'll do the second suture. Once both the sutures are through, you have to be careful that it comes out behind the iris, and then you can pass the second suture out. And once both your sutures are through, you can then tighten them and see that your ring goes well, it centers well. So you can remove the capsular hooks now that you don't need them, and you can pull out the sutures from the Hoffman pocket, and you can do a temporary knot to see that your bag is going to center well. And once you are sure that it's centering nicely, then you are ready to put in the lens and make these knots final. So this technique really works well for us because the capsular tension segment gives you just the right anchorage, and you can use two. If you are not confident about the zonular support on the other side, you could do a 2-point fixation, and here we got away by doing a 1-point fixation. This patient has been on follow-up for a few years now. It was a bilateral surgery. The good thing is that this knot is going to get buried inside once you cut the strands, and it goes into the Hoffman pocket. In fact, wherever possible, Hoffman pockets work really well because they do away with many of the complications that you see with extruded knots, and it looks really nice post-op. This child did really well and continues to do well. One more case I'll quickly show. This is a very hard brown cataract, and the problem here is that there is capsular fibrosis. So when we are trying to raise this flap of the capsule, we have run into an area where there is capsular fibrosis. I'm sorry for that virion overlay, which is actually interfering with our view of the capsule, but we decided to go around from the other side and reach that area where we had got stuck. You can see that there is fibrosis here and the capsule will not tear. So this is a potential weak area. We again initiate the rhexis from the other side and we bring it around. It's also a very hard cataract, so we need a slightly bigger rhexis. And the capsule is very friable and fibrosed and not a healthy capsule. So we are being extremely careful. So we have come around from both sides and reached the same area, and now we need to disengage, and we are able to do that, but see, we've left a small potential defect here, plus the whole capsule as it is not very healthy either, and this is a very, very hard cataract which we are going to try and crack and remove. I would have been happier with a slightly bigger excess, but under the circumstances this was the best we could get. This is about a 5 millimeter excess. And these are the cases where sometimes I really like doing femtocataract because they can make your excess much more predictable. You can also get a bigger excess as you want. And for these hard cataracts, it is also nice to be able to soften the nucleus and just see what's happening. Now we are doing lateral separation, and while we are doing that, and we do it a little bit too much, and there goes the capsule has probably given way there, and in this area we now have a small break in the capsule. So now we are in a soup because we have a broken rhexis, and at this point here you can see the broken rhexis right here, and we have the full nucleus inside. Now at this point, how many of us would like to convert to an extracapsular? Can you raise hands? How many people would want us to switch to an extracapsular or an SICS? Not too many. That means most people are in favor of continuing with phaco. On the panel, anybody would want to convert or continue with phaco? Kumar, what would you do at this point? Huh? You leave it?
You continue your talk, I said.
Continue.
You continue your talk, that's what he said.
Okay. Okay. Yeah, he wants
no
me to
problem.
finish. Okay.
I think we'll
so
continue.
now we are running short of time, so I'll quickly take you to the end of this surgery. We continued with the surgery. Now the principle is that you have to have minimal lateral separation forces. You have to make smaller and smaller pieces. You have to be careful not to stretch the back further, and then you can break the posterior plate. The principles all remain the same, but your forces have to be very, very controlled. Otherwise, this area where the capsule has given way is going to just go to the posterior capsule. And once you have that posterior plate broken, you can ease out some of these pieces anteriorly. Now, if you're lucky, you'll be able to go through all the whole case. If you're not lucky, you will have a complication. The risk of complications is high, so you have to use maximum expertise to bring out smaller pieces, not to stretch the capsular bag, and when you're easing out these pieces from inside, use a lot of viscoelastic, and as you ease out these pieces, you can be careful not to stretch any of the sensitive zonules, the capsular bag, and once you have to be very patient, don't rush through the surgery, and most of the times you'll sail home. And we were able to get everything out. The pupil obviously constricted by the end of the surgery. It was almost a 10-15 minute surgery there, and we were finally able to get the lens into the bag. So I won't hold us back from our special address, and I'll stop here.
Very good.
Thanks, Kumar.